Good evening, everybody, and welcome to another Catherine McEwan Foundation Facebook Live session. I'm very interested in tonight's session because all of the previous sessions we've had before, we have some recurrent themes running through them. And although coronavirus has been very common amongst them all, the other very common questions we've had are around stomas. So we thought after all of the feedback that we would have a dedicated session on stomas so we can ask specific questions about them. It's also very common during the Catherine McEwan Foundation events that we had prior to lockdown that people with stomas would feature as part of those, telling us their experience of them and also asking questions at family days. So I'm delighted tonight to introduce two people who have great experience and expertise in stomas, and I encourage you to ask questions in the usual way and also to share this presentation on Facebook as well. So first off, I would like to introduce Jenna. So Jenna, if you can just introduce yourself and just tell us a bit about yourself, please. Thanks for coming tonight.
Good evening, everyone. My name is Jenna Tarr. I am the paediatric stoma nurse specialist at the Children's Hospital in Glasgow.
Excellent. And Jenna, how long have you been doing that for?
I've been in this role for 5 years now.
Excellent. So really all of the practical questions that you want to ask around stomas that I know are very common, Jenna has vast experience with. So please think of your questions for Jenna. Second guest and expert tonight is Mr. Gregor Walker, consultant paediatric surgeon and newly appointed clinical lead. And I'm delighted he's here tonight, and he's going to introduce himself and then give a short presentation. And I hope just use the time during the presentation to try and think of your questions so we can start going into the question and answer session after Gregor's presentation. Gregor?
Yeah, so I'm Gregor Walker. I'm a consultant paediatric surgeon in Glasgow, and I worked with Richard when he was across with us, and we work very closely with the gastroenterologists, as many other hospitals do, not only with the gastroenterology team and the stoma nursing team like Jenna, but also the specialist IBD nurses as well, and we're very closely involved in children with inflammatory bowel disease. So do you want me just to go straight on with my presentation, Richard?
That would be brilliant. Thank you very much.
So I thought I would set the scene tonight just by giving a short presentation on stomas in inflammatory bowel disease. And as I've said, although you can see that the three of our names on this slide, there is a big team of people that are involved in the treatment of children with inflammatory bowel disease, and we're only part of that. You can see a very nice picture of our Children's Hospital in Glasgow on the left-hand side there. So if we go into the second slide, please, John. Everybody in this Facebook group knows all about the different forms of inflammatory bowel disease, and they can essentially be separated up into two broad types, and that's the type that involves predominantly the colon in ulcerative colitis and in inflammatory bowel disease unclassified, and that only involves the large intestine. So in these diagrams you can see how the bowel is arranged, with the stomach at the top leading into the small bowel, and then that joins on to the large bowel that then transports things down to the bottom. So in ulcerative colitis, obviously, the large intestine is involved in isolation, and the small intestine should really be spared. In Crohn's disease, any part of the bowel can be affected with the inflammation. And in children, predominantly, it's the lower part of the small bowel, but it can also be the large bowel. And the reasons for forming stomas are really related to where the inflammation occurs within the bowel and the complications of that inflammation. So we can move on to the next slide, please, John. So just a quick kind of bit of information about the small and large bowel. The small bowel, really between the stomach and then the colon, is where all the goodness from your food is absorbed. If you have inflammation of that, it stops it working properly, so you don't absorb things properly. And also that inflammation can then cause problems with pain and problems with how the bowel can push things through by making it narrow. The bowel is arranged in a very clever way with these little tiny fingers poking into the bowel and absorbing all those things. And when they become inflamed, it just almost becomes a flat sheet without anything being able to absorb properly. We move on to the next slide, please, John. The large bowel, the colon, really moves poo from the beginning of it, so on the right-hand side, all the way around to the bottom. During the process of moving things through, it absorbs water and salt. So by the time the small bowel is finished with your food, it's like a very thin soup. And by the time it gets into the colon, the water is absorbed. So by the time it gets round to the end, it should have turned into what we think of as being fairly normal sausage-like poos. Inflammation of the colon is called colitis, and I'm sure many of you are familiar with that term. And colitis means the colon does not work properly, so it can't absorb the water properly, so you end up with loose, watery stools and often pain. So if we move on to the next slide, and it's really just a big title saying the reasons why you may need a stoma in inflammatory bowel disease. And the next slide, please. Probably the most common reason for forming a stoma in inflammatory bowel disease is because of inflammation of the colon, that cannot be controlled by all the pretty amazing medical treatments that we've got in store now. We've certainly seen less children and less adults coming to require their colons removed because of all the recent advances in medication. But still, there are some people who either present very quickly with disease that's got out of control, or over a long period of time where we just haven't been able to get on top of things. And having the colon removed very often results in having an ileostomy. So if you look at the picture on the left-hand side, you see the diseased, very red colon. That gets removed. We often leave the very bottom part of the colon in place, called your rectum, and then the small bowel is brought out as a stoma, and you can see a picture of an ileostomy there with a very standard spout. I often say to people, it looks like a pink walnut whip, but I'm not entirely sure you can buy walnut whips in the shops anymore, but that's what it looks like to me. And you can see this boy sporting his stoma with pride. It's situated there on the lower right-hand side of the tummy, and the very loose, watery stuff comes out into a bag. One of the common reasons with ulcerative colitis of needing to form a stoma is when we're thinking of doing this operation called a pouch, which some of you may have some questions about during the session. A pouch is where you use a very clever technique where you take the small bowel and you fold it back on itself and then form this kind of J-shaped reservoir, which basically works a bit like a colon in terms of it storing your poo prior to going to the toilet. And when all the colon has been removed in ulcerative colitis, you can use this pouch of a small bowel to join the small bowel down onto the anus. And when you do that operation, very often you do a temporary stoma to stop things coming into the pouch as it's healing. The difference between that and the ileostomy I showed you on the previous slide is that we do something called a loop stoma, which is a stoma that looks a little bit bulkier than the one I showed you before, and it has two holes on either side. But the same kind of stuff come out of it, and it's still very watery stuff that comes out of that because it's the small bowel that's been formed as the stoma. If you have Crohn's disease and you develop colitis, you can't really have a pouch like that. And what we often do is after a temporary stoma, we may end up looking to join the bowel back onto the rectum that we've left in place. But for many children and adults with Crohn's disease that have colitis, they end up with a permanent ileostomy like I showed you in the picture before. We move on to the next slide that's called inflammation of the anus. This is a very common problem in children with Crohn's disease. About 1 in 5 kids will have very problematic inflammation around their bottom, which can cause a lot of problems, in particular pain around the bottom and very unpleasant discharge and leakage. Quite often the medical treatments that Dr. Russell and his colleagues are involved with will help with that, but in some cases it can become so bad, either because of these nasty ulcers or abscess formation or fistulas, which are a joint between the inside of the bottom and the outside of the skin, and we just can't get on top of that, and we may need to form a stoma in that situation. And the purpose of doing a stoma then is really to stop any poo getting near the bottom to let it heal. So the next slide, which is called Allow the Anus to Heal, is really the 2 positions that we would think of doing a stoma for somebody with inflammation around their anus that wasn't healing. An ileostomy, as I've already shown you before, quite often leaving the colon in place, but just letting the stuff come out into a bag and no longer coming out into through the bottom is probably the commonest thing we do in children. But very often in adults with the same kind of problem, they will have a colostomy. Now, that's not something we form very often in inflammatory bowel disease in children, but that's a stoma of the colon, which is often situated on the left-hand side, as you can see in the diagram there. Because the colon absorbs quite a lot of the liquid, it means the stuff that comes out into the bag is often much thicker and a bit more like a normal poo, and not the watery stuff that I was talking about with an ileostomy. And sometimes that makes them a little bit easier to manage, but it's really only used in this particular situation, and quite often it's not used in children. And the reason for that is in kids that have inflammation around their bottom, they've often got inflammation of the colon as well. So the last slide I really wanted to talk about is the possible complications of having a stoma. And I suppose I'm bringing these up, but really just to maybe spur people into asking questions about it. But if you have any of these complications, you won't need any reminders. So there's a slide here with lots of pictures of stomas. The one in the center at the top is what a stoma should look like, with a nice kind of spout on it. The one on the top is on top left is the overgranulation, which we can often see with stomas, and that's the body's healing tissue around the bowel itself and around the skin. And that can be a bit of a problem, and Jenna and her colleagues will often use special types of dressings and ointments to deal with that. Very occasionally in Crohn's disease, that overgranulation can actually be the Crohn's disease affecting the skin or the stoma as well, and we have to pay special consideration to that. My picture of a hernia is not fantastic, and really what this is meant to represent is a bit of bowel coming alongside and causing a swelling beside the stoma itself, and that can sometimes require further surgery, particularly if it's causing problems with how the bags are sticking. And in the last 3 things are things that can happen with a stoma because it's not really healed the way we want it to do. One is that the stoma pushes back into the tummy itself, causing retraction of the stoma, which can cause a problem because the liquid contents don't come into the bag all that well. We can sometimes see narrowing at the site of the stoma itself that can require surgery to widen it. And lastly, you can get this thing called a prolapse that looks like an elephant's trunk sticking out, which is the bowel snaking out through the stoma itself. And quite often that will require surgery to stop that from happening, because it can cause a problem with how the bags are sticking particularly. So those are all the things that I thought might be useful just to set the scene for any questions you may have about stomas. But I think I've probably done enough talking now, and I think it's time for your questions.
Gregor, thank you very much. That was an excellent overview just of what types of stoma you can have, and some of the common complications and practical questions. I guess maybe just if I can start with a question just to cover we always talk about complications of stomas. I think sometimes we forget first what are the benefits of stomas too. So I wondered if you and Jenna both wanted to speak about experience you've had of patients who've had stomas for Crohn's disease or colitis, and how they've been afterwards. So I guess just trying to balance what you said about the complications with some of the benefits.
Shall I start?
Yeah, please.
So I suppose alongside forming a stoma often comes removing the diseased bit of bowel. And quite often in children with particularly Crohn's disease and also ulcerative colitis, that very inflamed bowel has really got to a stage that it's caused all sorts of problems and really made you feel rotten. And removing that can actually make you feel so much better. And so it's not necessarily the stoma itself that's making you feel better, it's removing the diseased bowel that makes you feel better. But the stoma is a kind of necessary side effect of all that. But I think many of the kids that I deal with that have had stomas just feel so much better because that diseased bit of bowel is taken away. For the children that have got terrible disease around their bottom, I think having a stoma can also transform their lives because it gets to a stage that life is just intolerable with the problems they're having with their bottom. So having a stoma can definitely make things much better. So I think everybody wants to avoid a stoma. Most of the teenage kids that I deal with, a stoma is the worst thing that they think can happen to them. But in nearly every case that I deal with, by the time they've got to a stage of making a stoma, people feel so much better afterwards.
Okay, thanks very much. Jenna, what would your perspective be on that question?
So again, complementing what Gregor's saying, it's quality of life. Most of the families, reflect and then say, "Oh, I wish we had done this sooner." However, we're exhausting all medical therapy before we get to that surgery stage, and the teams will exhaust every avenue before we have to do that. We see a range of ages of children with IBD history. And teenagers being the kind of vast majority of it, but I'm so impressed with them about how they can reflect on it for being a positive part of their life and being able to move forward. It gives them a new lease of life, they have more energy, and they're able to do things that they might not have been able to do before. So I think quality of life is the big part of it.
And what is the commonest reason, do you think, for patients being worried about having a stoma? What's the biggest practical thing they maybe say to you? Because I would share both of your experience that it's a very positive thing for the majority of people who have a stoma, but so many people are very reluctant to have the operation. So what's the biggest thing that people say to you that they're worried about?
Biggest thing, especially with teenagers and older children, is body image. That can be one of the first questions. The second one I'd say is it sore? Because anybody that hasn't seen a stoma, hasn't been aware of one before, or not met anybody that's had one, because of the colour of it, people automatically think it's painful. And obviously you're defecating into a bag rather than normally through your bottom, and there can be a lot of I think because we live in Britain, there's a lot of stigma around stool and poo, and if you have IBD, you've came through a long journey to get to where you have. So being able to see these patients as much as we can pre-operatively to reassure them and make sure that we can basically get them to the level they need to be.
Yeah, okay, thank you very much. Please keep asking your questions. We want to get through as many questions as we can. If there are questions which are very personal to you, but you want to ask them and you think other people would learn from them, you can ask your questions anonymously, or you can email them and we can ask them that way. So please do ask the questions. First question, Gregor, your presentation came across very well on Facebook. I know you couldn't see it as it was happening, but all of the slides were very clear.
Good, I'm glad.
Jacqueline Grant has asked a question, how common are stomas for IBD in children? So how often do they need to be formed?
Well, I suppose, Richard, you may be a very good person to answer that question as well, because you've been involved in various UK-wide registries for children with IBD and knowing how often they result in surgery and stomas. In ulcerative colitis, I think as children up until their teenage years, you can correct me if I'm wrong here, but I think probably between 10 and 20% of children with ulcerative colitis will end up coming to a colectomy in their childhood years, and that will result in having a stoma. It is sometimes possible to do that pouch procedure without a stoma, and some surgeons will be able to do that, but it's quite often done in a staged way with a stoma. So nearly always having this pouch procedure and having your colon out for ulcerative colitis will result in a stoma at some stage. For Crohn's disease, thankfully the chance of having a stoma is less than that. Although the chance of having surgery may be quite high, we can often do the surgery without the need for a stoma. But in terms of the disease around the bottom, it's thankfully, again, it's only a very small minority of children who end up needing a stoma for that reason.
Yeah, I mean, I think it's a hard question to answer precisely, but I would agree with what you said about between 10 and 20% of patients with ulcerative colitis needing a colectomy. It's probably just worth saying a little bit about that stoma, what type of stoma it is, and how long patients have it for, because one of the questions which comes up from patients commonly is, am I going to have this stoma, or I'm going to have this bag for the rest of my life? So maybe between you and Jenna, can you just talk us through the stoma that you get for ulcerative colitis and how long in general it lasts for?
Again, that's a slightly tricky question to answer, because I know that practices in the UK are maybe a little bit different in different centres in terms of how children are put forward for that pouch surgery that I've mentioned to you. In many centres, children will have their colon removed and a stoma formed. And then once all the inflammation settles and the medication is reduced or is stopped altogether, the children move forward with a pouch procedure. Quite often, that will be when they're a little bit older. Very occasionally, we'll do them in younger kids, but you'd normally wait at least a year or so after forming the stoma before going on to that next stage. When you've had the pouch procedure itself, when you have that loop stoma that I mentioned, you tend to have that for around about 3 months to let the pouch heal up, and then the stoma is closed with another operation, so you start pooing out of your bottom again through the pouch. In some centres, they are not keen on doing the pouch procedure in children, so if you have a stoma as a child, you would often have that stoma until you get into adult years, and you would have the operation done by adult surgeons, usually in your late teenage years. So that does mean having the stoma for considerably longer.
But most of the people watching will be in Scotland, Gregor. Okay. So for most colitis patients in Scotland, they're going to have it for a year. Yeah, ballpark figure about a year. Once all the medication is stopped, moving forward with the pouch procedure, and then there's another stoma for around about 3 months after that before it's closed again. Okay. In Scotland, that would be a typical journey, I would have said. So Jenna,
obviously, if you're very young, we might wait longer than that till you get a little bit bigger. Yeah. Sure. Sorry, Richard.
That's okay. Jenna, can you tell us, so that's an ileostomy that would be formed for that type of surgery as a temporary thing. What are the kind of practical issues around looking after that kind of stoma for patients and for parents?
So the first one would be the consistency of the poop that's coming into the bag. As Gregor had said earlier, the poo that comes out there is much runnier than it would be further down in the bowel. So that can cause a bit of problem sometimes with leakage and the stool getting underneath the appliance and under the bag. Now, in the stoma world, we have numerous options. We actually have too many options, which sometimes confuses people about how to manage these types of leaks and manage the skin, which is possibly going to be damaged underneath it. I'd say that getting the right appliance can be quite tricky. It's something that sometimes doesn't happen overnight. and a big part of my role is to advocate what I think is best for the patients. Besides the problem leakage, skin irritation would be one of the big ones.
So appliance, you mean bag and bit that sticks onto the skin?
Yes.
Yeah.
So, for example, this part here, or the base plate here.
Okay. And from a patient point of view, how often are they going to need to empty and change those devices, appliances?
So for an ileostomy, you're looking at possibly emptying 4 to 6 times a day, depending on how loose the losses are. Changing the appliance, we try to stick to every 2 days, try and keep skin integrity as best we can. In paediatrics, we are very lucky that we have lots of nice adhesive removers. These are just a couple to show you. That we are very lucky because in the adult land, we don't get them at all prescribed. So they are very lucky if they do start their surgery journey with us, because we get started on that. And the reason that we do that is to try and keep skin integrity when they're little. Skin is not quite as developed as when you're older, so trying to keep that as best as possible and trying to keep nourish that before we take the bag off, so there's no pulling, there's no scratching of the bag. Although I do have some patients that don't use adhesive remover, they think it's too much faff and just take the bag off. However, we are lucky to have it. We have other things to help with the surrounding skin that we do use. Frontizan, which is a big favourite. For skin irritation and problems with that. And one of the other things is a skin barrier, which is really important, especially in paediatrics. Again, there's a variety of different ones you can use. We have little wands like so that look like this. We also have sprays that look a little bit like this, or a little bit like the can before. And I think for some patients with an ileostomy, navigating that can be one of the hardest things. I find even nurses sometimes look at stoma wash bags and think, oh gosh, it all looks a little bit too much. But actually the steps are all the same. It's just there's so many manufacturers out there that do the same thing. We have a little bit too much choice. So that's a big part of my role, trying to guide families to the best options for them.
And you know, the common worry that certainly comes to our clinics is how teenagers will deal with these in high school. And, you know, what if they have to change things or empty things in high school? How easy is it to do?
So with high school, with the patient's permission, I always try and visit the high school along with the patient. I try and do it myself to start off with, because we can kind of lay the land and see the facilities that are there, make sure there's appropriate facilities. I don't particularly want to leave my patients feeling vulnerable, that they have to have a separate toilet or anything like that. There's other accessories and different things out there that they can use in the main public toilet. And one of the big concerns is odour, especially going to high school. So I normally say to pop a little can of something in their wash bag with them, a Lynx or an Impulse or something along those lines. One of the manufacturers actually brought out an adhesive remover that's got a scent in it, which is a very good one for teenagers. That's got a minty kind of fresh smell, which does help with that. Disposable wise, there's nothing fancy you need to do disposing it. It goes in the normal bin, and basically just be able to support them as best we can. We try and speak to the guidance team and make sure that we can be there for them, and they have supplies in the school if need them.
What's the spray called that has the scent in it already? This
one is the mint one, and it's called Ostopeel.
All right. Okay. I've never heard of that. Thank you very much. So we've gone through colitis there, Crohn's disease. I don't think you gave a figure, Gregor, and I can completely understand why that would be. I guess what we would say overall is patients with Crohn's disease, although, as you said, they're more likely to have surgery, they're less likely to have a stoma. But maybe 5 to 10%, I guess, of children might need that. I guess the common question here is how often is that stoma forever, and how often can that stoma be reversed? And I know it's a slightly controversial question, so I understand. Well, what's your answer? What do you think?
I think, as you know, Richard, because we've spoken to lots of families together in this situation, when you're doing a stoma like this for Crohn's disease, particularly if you've had to remove the colon, I think really when you come into that, you've really already exhausted most of the medical treatments that are available, and usually at that stage we'll say to people, it's very likely that this stoma is going to be forever. However, we know that there's advances all the time, and medical treatments change, and it may be that with different newer drugs would be able to keep the inflammation under control, and the stoma could be reversed. Generally speaking, the operation to reverse the stoma is a pretty straightforward one from a surgical point of view. But the big problem is sometimes the bowel that's no longer had any poo into it settles down, but then when the poo starts coming through into that bowel again, things can flare back up again. So although a lot of teenagers will be keen to have their stomas reversed and no longer have a stoma, there is definitely a very high chance of things flaring back up again after doing that. So although I'm definitely one of the types of surgeons that would be very prepared to do that, we all need to go into it with our eyes wide open about that possibility. So usually in Crohn's disease, the stoma will be not necessarily permanent, but long-term, to answer your question.
And I think, but what we might say is that the potential for reversal is there.
Yes.
And although during teenage years, that potential might not be realised, there may be, as you say, changes in the future which allow that to happen. I wonder if we might just talk a little bit about colostomies. You said in your presentation they're less common, but some patients do have them. Yeah. Jenna, can you tell us the practical considerations maybe that are different between colostomies and ileostomies? You've gone over very well the practical issues around ileostomies. What about if we're in the situation where a patient, for whatever reason, has had a colostomy formed, and then we'll maybe ask Gregor what those conditions might be where you would get a colostomy instead of an ileostomy.
Okay, so the practicalities are pretty similar to the ileostomy, but hopefully there'll be less instance of that. The stool which will come out of the colostomy will be hopefully a bit firmer, not sometimes always the case in patients with IBD. But one of the other things to note is sometimes colostomies can be quite flat compared to ileostomies. Sometimes there can be a little bit of a difference with adhesion. With the bags, there can be the risks of prolapse and retraction as well, which was mentioned earlier. Colostomies would empty less times during the day, and the biggest probably difference would be the type of appliance that you could use with a colostomy. So rather than it being a drainable bag, which you can drain out for an ileostomy, you can actually use a closed bag, which doesn't have that drainable part at the bottom. And rather than emptying your bag a couple of times a day, you would change the bag entirely, which a lot of my teams actually prefer, especially if they've got a colostomy for a different reason, as well, for a different disease or reason for having it. And sometimes my teenagers prefer that because they prefer to change as much as possible. All of my teenagers, I would probably say, we do aim to leave the bag on for 2 days, especially with a drainable one. But a lot of my teenagers will change daily just because that's their preference and that is what they want to do. And if that makes them feel more reassured and more comfortable, then that is absolutely fine with myself. I have found in the past, though, that moving to adult services, that sometimes can be a little bit more difficult because of the constraints that are around prescriptions and use of products. So sometimes it's back to every 2 days, but we try and negotiate that, and I try and prepare my patients for that as they move forward as well. Okay,
great, thank you. So it sounds practically, in some instances, colostomies might actually be easier to look after, Gregor. So why can't more children have colostomies, or which ones are suitable for them?
Well, I think the most common situation for having a colostomy, as I've said, is when you've had terrible inflammation around the anus or complications from that. But the colon must not be inflamed. And if the colon is inflamed, then a colostomy would not be a good idea, because you're actually not dealing with the other problem, which is the inflammation of the colon. But this is something that's quite often done in adults who more often have problems around their bottom without inflammation of the colon at the same time. And I would assume if it happens in adults, it must happen in older teenagers as well. I can only think of 1 or 2 kids in Glasgow that have had a colostomy for that reason. The vast majority have had ileostomies because they've also had inflammation of their colon. I mentioned before that when you have ulcerative colitis, usually all of the colon is involved, but in Crohn's disease, that's not necessarily the case. You can sometimes have just parts of the colon involved. And again, there are some situations where if only part of the colon is involved and it's removed, you would bring out a stoma in the healthy bit of colon above it. In our experience, we've rarely had that situation, but I do know there are some children in the UK that have had that, where they've only had part of the colon removed and a colostomy brought out. Okay. The most common reason would be the inflammation around the bottom.
Yeah. So for most patients with colitis, it's not going to be a suitable option at all because they have inflammation of the whole large bowel. That's not going to be a good idea. And for a minority of patients with Crohn's disease, whose Crohn's disease is limited to around their bottom, then it might be an option for them, but it's an unusual operation to do. We have a question from Lucy Proctor, who is asking about recovery time from a J-pouch. So I guess you touched on what a J-pouch was. I guess maybe it would help to just explain it in slightly more detail, looking about the 3 stages of a typical operation, and perhaps describing a little bit about the J-pouch so people can understand about the recovery time from it. Do you want to start with that, Gregor?
Yeah, sure. So maybe we talk about this happening in 3 stages. The first stage has nothing to do with the pouch at all. The first stage is removal of the colon and the ileostomy being formed. The recovery after that, I suppose, depends a little bit on the medicines that you've been on in advance and how much of a toll that's taken on the colitis itself has taken on you. And it also depends a little bit on how the operation was performed, because as many of you know, you can do these operations using the kind of standard operation, which is a big cut running up and down the tummy, or you can do them using keyhole surgery, laparoscopic surgery. We've definitely done a few laparoscopic colectomies in Glasgow, and the kids do tend to bounce back pretty quickly from that. So the recovery time in terms of the duration of time in hospital from a laparoscopic procedure like that would probably be around about 3 to 5 days, whereas with the larger operation with the bigger cut, you're usually in hospital for at least 7 days, if not 10 days. That's not the end of your recovery, of course, after you've left hospital, because you'll still feel a bit washed out for a period of time. An awful lot of that is related to the wound itself. So children who have had the keyhole surgery operation will often get back to school and back to normal activities after a few weeks. But with the bigger cut, it can take a bit longer than that. And usually about a month off school with a very phased return is to be expected. So that's the colectomy, or the removal of the colon part of it. Then the next operation is this clever operation where you basically turn a part of the small bowel into a kind of colon substitute, and it's called the pouch procedure. And I showed these pictures earlier where that's done by taking the long tube of the small bowel and folding it back on itself, and then stapling it so you have a wider reservoir that can hold on to the poo and store it. It doesn't necessarily, in fact, it doesn't turn it into a more solid poo, because it can't really do that, but it does act as a reservoir. That operation itself, again, can take quite a bit out of you, and it's nearly always done using the bigger cut, although very occasionally it's done using keyhole surgery in the UK, but not in Scotland at the moment in children. And again, you're in hospital for around about a week after that. And the wound is probably the thing that will hold you back most straight after the operation. So again, expecting to be off school for around about between 2 and 4 weeks afterwards would be expected. By the time you have the operation to close at the third stage, which is to close the stoma so you start pooing out of your bottom, we often see kids going home pretty quickly after that, actually. It's a fairly straightforward operation, and they would go home usually within about 3 to 5 days after that. That's when you start getting used to your pouch, though. And the recovery after that particular operation is really related to if you have any problems with the pouch itself. And it's probably just worthwhile mentioning the kind of problems we see with pouches. And the most common problem is inflammation of the pouch itself, what we call pouchitis. And that really happens probably in about a third of people that have this pouch operation. That needs to be dealt with by different medicines and occasionally suppositories to try to get on top of that pouchitis. But it's important to say that for about 5% or about 1 in 20 people who have pouches in that first year, it just isn't what they wanted. And they end up deciding to no longer have the pouch and poo out their bottom and have a stoma again, because life was much better with a stoma.
Okay, thanks. Jenna, I know that probably you don't see that many patients with pouches, because the time they've had their pouch, they no longer need to be your patient because you're a stoma nurse. But Lucy has asked a follow-up question, I think around gas production and how you deal with gas with pouches, and I guess it's worth talking about that in stomas in general. So people are very worried about gas and noise and other things. What kind of practical tips do you give to people with stomas who have that as a problem, or often as a perceived problem?
So the stoma likes to challenge you sometimes. I think one of the big things, especially if I meet people before their surgery, is to get to know your stoma. That is what the kind of main thing to take away from it. Your stoma will fart, it will burp, it will cough, it will do what it likes, and sometimes at the most awkward of times in the most quietest of rooms, and you don't have control over that. So one of the things I do kind of say to my patients, especially my teams, that being prepared for it is the kind of most important thing. So we talk about this prior to surgery, so it's not a shock when we come after. I think a lot of people learn to cough loud when they feel it coming. A lot of people do a bit of a cough to try and disguise it. A couple of my patients have actually taught me a few tips about this as well. So noise can be noise can actually be prevalent with bags as well, which is something that I didn't mention earlier. I think many years ago, when bags were being manufactured, they were kind of a little bit kind of papery, but now the materials that we're using are much more softer, but patients do complain about the noise of the actual bag itself. So keeping your arms kind of to yourself, especially if you're in a classroom or an exam, and keeping your hand over the bag can sometimes be a little bit beneficial. Or if we're talking about that, popping a Tic Tac into the bag can sometimes help if you're not wanting to use all different things. I've seen other people use things like toothpaste and things like that, but that's a bit messy to me, a Tic Tac I've used before. So yeah, I think preparing you for that and getting to know it. A lot of my patients have come back to me and said, well, if I eat such and such, I know that I will be looser. If I eat such and such, I will have this type of whatever output. So I think it's really important to get to know it and try different things, try different foods slowly at home where you're comfortable, before then kind of going out and about. And that gives you a little bit more confidence in what to expect when you do, are out in public or out with your friends or in the cinema.
Okay. A lot of patients do get to know their stoma very well, and a lot of them give them names as well. Is that, how common is that? Is that just the people I've seen, or is that a very common thing to do?
Really common. I actually encourage it with all of my families. Some of my teams look at me as if to say, I'm not doing that. However, it's very patient dependent, but I think it gives you a real sense of how the patient feels about their stoma. For example, I had seen an adult stoma nurse do a presentation many years ago and she had started this kind of ethos, because in paediatrics we do it quite often. We kind of do things without thinking. So she had done this with some adults, and it actually reflects what the patient thinks about their stoma. So I've got one patient who calls hers her handbag. I've got a little boy who calls his transformer. And it actually helps if you're out and about in the supermarket, rather than saying, "Mum, I need to go and fix my stoma," just say, "Mum, I'm just going to sort out my handbag." And it is a bit of like a kind of code word as well. So I think that gives patients a bit of a reassurance, and lets them kind of identify with it as well. But I actually have some patients that they've all got names now, and I need to try and remember everybody's name, because that's how we talk about it. So I need to be on the ball with who's calling what who now, because we have so many. And I think it's a really good thing to try and encourage families to do that.
Yeah, I agree, actually. Gregor, is there anything you want to add, either about what Jenna said practically about gas and things, or names, or?
No. I think, I share Jenna's problems in trying to remember everybody's stoma's names. I'm terrible at doing that. In terms of the gas production, sometimes, I'm sure Richard, you'll agree with me, that can sometimes be helped by different antibiotic regimes, because you can sometimes have increased gas formation from some bacteria, which you expect to be in the bowel, and we can occasionally deal with that, and that can sometimes improve things, particularly with pouches.
Great.
One area of when, sorry to interrupt you, is sometimes on an aeroplane, not that anybody's going on a flight anytime soon, but that's one of the things which a lot of my families weren't prepared for, is no matter, even if your bag is completely empty and you've cleaned it and emptied it before going on a flight, it will blow up, and it's because of the cabin pressure. And I think that's something else just to prepare families for as well, because no matter what they do, it will still blow up. My other half's actually an aircraft engineer, and I've set him the task of figuring out if he can do anything about this in the future. So I think it's just making sure you're prepared and you know what to expect, and we try and cover as much of that as possible.
Thank you very much. I think we've covered most of the questions that have come through tonight. Jacqueline Grant, if I can just say, I know your question wasn't directly related to stomas, so I'd advise you just to talk to your local IBD team, as it sounds like your son probably has active Crohn's disease just now. So I would just seek some advice from them, either by email or telephone. I wonder if we can just finish up by, if people have further questions, are there any good resources they can go to look for further information, either digital or written? Any practical guidance from either of you? Jenna, do you want to?
Yeah, most of the stoma companies out there all have really good websites. For example, Salts, Coloplast, Dansac, Hollister. They all have very, very good information, and if there's also the IA Ileostomy Association, which is very good for support, and the Colostomy Association as well. I work very closely with a charity called Buttonny Bear, which is a charity around stomas in children. Jenny Gow, who is the runner, lives up in Aberdeen and has personal experience, and she's extremely good at supporting, and we're trying to have a little bit more support around patients with stomas in the future. Unfortunately, family days don't look like they will start up anytime soon again, so we may look in the future to do something like this for families that are looking to possibly waiting for surgery or considering surgery. That might be a possibility for the future.
So we'll be about that. That sounds like great resources there, and for everybody listening, we'll try and put up as many of those links as we can onto the Facebook page after the session is finished. Gregor, anything you want to add to what Jenna said?
No, I suppose there's also specific pages on Crohn's and Colitis UK and KICRA as well, and I think the most important thing here is seeking advice from the correct people and sharing your own stories. And I know that many of the families involved with this will go to family days, and I think that's a great resource to get advice from other people to see how they're coping with things as well. So sharing your experiences is often very helpful for people.
Thank you very much. Well, I think we'll bring it to a close there. We've had great practical advice from Gregor and from Jenna. Gregor mentioned walnut whips. Jenna mentioned Tic Tacs. I'm not sure I've got a particular sweet to round off with, but I think it's been a really helpful and practical walk through all of the common questions around stomas, and I know and would like to thank you all for your positive feedback through the Facebook page. Please share this as much as you can, and we'll see you again in a few weeks for another session. Thank you very much for watching. Please like the page. Bye, everybody.
It's us.